Hello, my name is Dr. Anop Lekakun. I am a clinical research fellow in the Division of Cardiovascular Ultrasound at the Mayo Clinic. I'd like to take this opportunity on behalf of myself and my colleagues in the Department of Cardiovascular Diseases here at the Mayo Clinic, Rochester, Minnesota, to discuss our research, which we report in the Mayo Clinic Proceedings. The research paper is entitled "The Incidence and Management of Hemopericardium: The Impact of Changing Trends in Invasive Cardiology." Over the last 2 decades, there have been fantastic advances in cardiovascular care. Many cardiovascular diseases can now be managed successfully with sophisticated surgical techniques, the implantation of pacemakers and defibrillators, and a variety of minimally invasive percutaneous options for the management of coronary disease, heart rhythm abnormalities, and more recently, valvular disease. However, as this invasive cardiovascular care has become increasingly complex, there has been an increase in the rare complication of cardiac perforation, leading to blood in the pericardium or hemopericardium. When blood enters this enclosed sac, there is a high risk of cardiac compression that impairs heart function, a potentially life-threatening condition known as cardiac tamponade. At the Mayo Clinic, we have a management strategy to deal with this complication, whereby a small drain is placed into the pericardial sac under ultrasound guidance to drain the fluid, and a procedure known as pericardiocentesis. The goal of this research paper was to assess the frequency, etiology, and outcomes of hemorrhagic pericardial effusions managed through a non-surgical echo-guided percutaneous strategy over a 10-year period between 2007 and the end of 2016. Over this 10-year period, of a total 1,097 unique patients who underwent pericardiocentesis, 411 of them had drainage of hemorrhagic pericardial effusions. When compared to institutional historical data, there has been a significant rise in the need for pericardiocentesis over the past 3 decades, with the difference related predominantly to a significant rise in the incidence of hemorrhagic pericardial effusions. The majority of these hemorrhagic effusions need to be emergently drained, and the majority drained through access sites on the left anterior chest wall, or less often the right anterior chest wall, or rarely subxiphoid. Most of hemorrhagic effusions occur following the percutaneous interventional procedures such as cardiac ablation, device lead implantation, coronary interventions, or cardiothoracic surgery. A smaller number occurs related to cancer or inflammatory pericarditis. With regards to the timing of pericardial synthesis for hemopericardium following cardiac interventional procedure. The majority of patients who develop hemopericardium following cardiac procedures, including ablation procedures and percutaneous coronary intervention, present and require pericardiocentesis acutely, whereas hemopericardium developing after pacemaker is more commonly delayed, presenting days and even weeks after the date of device implantation. The short-term outcomes of patients with hemopericardium undergoing pericardial synthesis were good. Almost all cases of pericardial synthesis were successful. In 5% of cases, although the pericardial synthesis was successful, same-day surgery was needed to address ongoing bleeding or treat the underlying cause. In a further 4%, a delayed intervention was needed to address the underlying cause. Most commonly, a revision of the device lead. Longer-term outcomes were also good, with mortality over 5 years of follow-up for patients with hemorrhagic effusions was better than patients who required pericardial synthesis of non-bloody effusions. This difference is likely related to the higher proportion of cancer or systemic inflammatory diseases in patients with non-bloody effusions. In conclusion, the echocardiographic guidance allows rapid, successful pericardial synthesis in the setting of blood in the pericardium related to microperforation from interventional procedures, cardiac surgery, malignant, or pericarditis, with the majority not requiring surgical intervention. Surgery should remain the first-line approach for aortic dissection or myocardial rupture. I hope you enjoy reading the article. Thank you.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.